Hello and welcome. Today we're diving deep into a rare kidney disease called immunotactoid glomerulopathy, or ITG. This condition, characterized by unique deposits in the kidney's filtering units, can lead to serious health complications. Join us as we explore the intricacies of ITG, from its causes and symptoms to diagnosis and treatment. The exact cause of immunotactoid glomerulopathy remains somewhat of a mystery. However, it is strongly associated with underlying conditions. A significant portion with IV patient G have monoclonal gammopathies, meaning they produce an abnormal amount of a single type of antibody. It's also linked, though less frequently, to certain infections like hepatitis C, autoimmune disorders such as systemic lupus erythematosus, and even some cancers, particularly lymphoproliferative disorders like lymphoma. In some cases, no underlying cause can be identified. These are classified as idiopathic ITG. ITG is primarily a disease of the glomeruli, the tiny filtering units within the kidneys. The hallmark of ITG is the deposition of organized microtubules of immunoglobulins, typically Ig, within these glomeruli. These microtubules, visible under electron microscopy, appear as parallel or radiating structures, sometimes referred to as tactoids. These deposits trigger inflammation and damage to the glomerular capillaries, impairing their ability to properly filter waste products from the blood. This ultimately leads to protein leakage into the urine and a decline in kidney function. Immunotactoid glomerulopathy is considered a rare disease. Precise epidemiological data is limited, but it is estimated to affect a very small number of people worldwide. While it can occur at any age, it is most commonly diagnosed in adults, with a slight predominance in males compared to females. Due to its association with underlying conditions, the apparent incidence of ITG may vary depending on the prevalence of those associated diseases in different populations. The symptoms of ITG can be varied and often develop gradually. The most common presenting feature is proteinuria, the presence of excessive protein in the urine. This can lead to edema or swelling, particularly in the legs, ankles, and around the eyes. As kidney function declines, patients may experience fatigue, high blood pressure, and eventually progress to kidney failure, characterized by symptoms such as decreased urine output, nausea, vomiting, and shortness of breath. Diagnosing ITG requires a comprehensive approach. Initial investigations usually include blood and urine tests to assess kidney function and detect proteinuria. The definitive diagnosis, however, is made through a kidney biopsy. A sample of kidney tissue is examined under a microscope, including electron microscopy, to identify the characteristic microtubular deposits within the glomeruli. Immunofluorescence studies are also performed to identify the specific type of immunoglobulin present in these deposits. Further testing is often done to identify potential underlying causes, such as monoclonal gammopathies or infections. While ITG doesn't neatly fall into distinct subtypes, it's often categorized based on the type of immunoglobulin involved in the deposits. Most commonly, the deposits are composed of Ig, but cases involving IgM or IgA have also been reported. Additionally, ITG can be classified as primary or secondary, depending on whether underlying cause is identified. Distinguishing between these categories is important, as it may influence treatment strategies. Treatment for ITG focuses on two main goals: managing the symptoms of kidney disease and addressing any underlying cause. Medications commonly used include corticosteroids and immunosuppressants, such as cyclophosphamide or rituximab, to reduce inflammation and suppress the immune system. Angiotensin-converting enzyme inhibitors or angiotensin receptor blockers are often prescribed to lower blood pressure and reduce protein leakage in the urine. If an underlying condition, such as a monoclonal gammopathy or infection, is identified, treatment for that condition is crucial. In advanced cases of kidney failure, dialysis or kidney transplantation may be necessary. Unfortunately, there are no specific preventive measures for immunotactoid glomerulopathy, primarily because the exact cause is often unknown. However, individuals with underlying conditions known to be associated with ITG, such as monoclonal gammopathies or hepatitis C, should receive appropriate monitoring and treatment to potentially reduce the risk of developing ITG. The prognosis for immunotactoid glomerulopathy can be variable. Some patients respond well to treatment and experience stabilization or even improvement in kidney function. However, others may progress to end-stage kidney disease requiring dialysis or transplantation. Factors that influence prognosis include the severity of kidney damage at diagnosis, the presence of underlying conditions, and the response to treatment. Recent research is focused on better understanding the mechanisms underlying ITG and developing more targeted therapies to improve outcomes. Studies are investigating the role of specific immune cells and signaling pathways in the disease process. Additionally, clinical trials are exploring the efficacy of newer immunosuppressive agents and monoclonal antibodies in treating ITG.